Bismillah ar-Rahman ar-Rahim. My name is Ayman Muhammad Hafiz Yusuf. I'm an assistant lecturer of hematology at the Internal Medicine Department, Hematology Unit. Now we'll be discussing and illustrating how we should approach the cases clinically in terms of the objectives we will be mentioning later on, including the splenomegaly, how to examine for spleen, how to examine for the cervical chain lymph nodes, how to examine the extremities in both lower limb edema and any bleeding signs of the lower limbs, and how to address the CBC when it comes to the Osce station examination. This is Rocky, our patient, and he agrees to be participating in this educational tape. First of all, I'll be starting with the spleen examination. The Osce station regarding the spleen examination will come in form of examine the spleen or palpate the spleen. So I'll be asking Raghi if he can lie down on the street in a recombinant, on the bed in a recombinant position with a flat bed position. راقي لو تقدر تنام وتفرد ظهرك على السرير. The first step in approaching the patient after introducing ourselves and what we are going to do to the patient is to put the patient in the correct position and to expose the part to be examined well. So first I'll ask Raghi if he can take the appropriate position for palpation of the spleen. راقي معلش احنا هنكشف بطنك تمام، فهننزل الغطا تحت رجليك وهنرفع شويه الغطا كده لحد صدرك من فوق، وعايزينك تتني رجليك على بطنك شويه بس، ولو تقدر تحط ايديك جنبك كده. So this is the correct position if you are trying to approach the patient for examining the spleen. He should be in a flat recombinant position, hips must be flexed, and the arms must be resting on his both sides. In addition, the exposure. Exposure for the abdominal examination should start from the nipple line above the xiphy sternum down to the genitals. However, the genitals exposure may not be convenient in this setting. They can be illustrated to the examiner that the genitals are part of the abdominal examination. But regarding the spleen palpation, we are not exposing the genitals. Should be standing on the right side, and the right side should start by a superficial palpation. Even palpation of the spleen should start by superficial palpation, and here start from the right iliac fossa using the palm, just resting the palm of my right hand and passing it all over the 9 abdominal regions, going from the right iliac fossa to the suprapubic to the left iliac, left lumbar, left hypochondrial, epigastric, right hypochondrial, right lumbar, and then going back to the periumbilical region. After doing this superficial palpation, we are doing a deep palpation to the spleen. And a deep palpation of the spleen, we start also from the right iliac fossa while asking the patient to take deep breaths. So راقي ممكن تاخد نفس معايا؟ كمان نفس؟ كمان نفس؟ كمان نفس؟ كمان نفس؟ كمان نفس؟ كمان نفس؟ As you see here, the direction of our palpation should be from the right iliac fossa to the direction of growth of the spleen, which is upward and to the left. We are using our radial indices, our radial margin of our indices against the downward movement of the diaphragm while the patient is taking his breath to feel the pull of the spleen. Once we feel the pull of the spleen, we have to define the splenic border, which is the sharp border that can be felt from the ball of the spleen up to the costal margin. This is called the splenic border. While we pass our hand alongside the splenic border, we can define what's called the notch. The notch is a depression along this sharp border. Then we can move our hand over the surface of the spleen to feel the nodularity, and if there are any smoothness or sharpness regarding the surface of the spleen. During the splenic palpation, we have to notice how the spleen moves with the respiration, because this movement is important in differentiating left hypochondrial swelling. Our comment on the spleen should include where exactly we felt the pole of the spleen in distance from the costal margin, which can be expressed in finger breadth width or in centimeters. In addition, we have to describe the border of the spleen, the notch of the spleen, the surface of the spleen, whether it's smooth or nodular. We have to mention whether the splenic palpation was tender by inspecting the facial expression of the patient. And we have to tell the consistency of the spleen in terms of firmness, being soft or being hard in consistency. And the last thing to do regarding the spleen is to do the bimanual palpation to tell whether the spleen is pulsatile or non-pulsatile. However, the bimanual palpation should be held from the left side of the patient. So we must be standing on the patient's left. On the patient's left, I'm using both hands, not only my right hand, to have a firm grip over the spleen. The right hand just below the spleen and the left hand over the spleen, and I can squeeze the spleen in between my both hands to feel the splenic pulsations. After giving the comment on the spleen, telling the extent of the splenic pool from the costal margin, describing the border of the spleen, describing the notch, describing the surface of the spleen, giving comments on the consistency, tenderness, mobility with the respiration, and whether there are or there are not any pulsations felt by bimanual palpation. Here we fulfilled all the items required for the splenic palpation. And the last thing is to perform other tests on spleen in circumstances in which the spleen may not be filled by the usual splenic palpation. Like having a very small spleen just below the costal margin, where we can do the hooking method. And hooking method must be done as well from the left side of the patient using our right hand, our right tips hooked just below the costal margin to feel the splenic depth movement with the respiration. The other ways of examination of the spleen in ascetic patient, in cases of tense ascites where the spleen is floating and we cannot feel the spleen because the abdominal wall is so tense, we can use a dabbing method. And the dabbing method is just using a small dip of the spleen, just pushing the spleen abruptly downwards, and the spleen by its weight, and because it's floating, because of its lower density, it will come back and hit my hand again. This is called dipping method of spleen examination. Those other techniques of spleen examination are usually not requested in a routine palpation of the spleen unless those circumstances happen. Otherwise, the examiner is going to tell you and ask you questions regarding the differential diagnosis of this splenomegaly, whether it's tender splenomegaly, hepatosplenomegaly, huge splenomegaly, and what are the differential of those cases. Thank you. And the next station will be examining the cervical chain of lymph nodes. And the cervical chain of the lymph nodes lies in two groups. The first group is the circular group, which are arranged around the skull and the mandible of the patient. And the second group is the vertical group, which are arranged around the great vessels of the neck, mainly around the sternocleidomastoid muscle. Before approaching the patient, must do the hand wash using sterilium or a sanitizer or an alcohol. After washing hands with alcohol and drying the hands with paper or something, we are asking the patient to put his hand in the correct position for the examination. And the correct position of the examination for the circular group of the cervical chain should be in the middle position, not so low, not so high. While supporting the patient's head with the hand, the other hand should feel the lymph node underneath the bony eminences. And the first to be felt is the submental lymph gland. In the submental lymph gland, we take the submental tissues and roll those tissues against the submental or the mental prominence. The same should be done on the submandibular lymph glands. So we should be taking the submandibular tissues and roll them against the mandibular margin. And we have to use the terminal phalanges and the palmar surfaces of the terminal phalanges in the rolling movement in order to feel the bead-like structures which are the lymph glands. Over the ramus of the mandible where the parotid lies, we can feel the preauricular lymph gland. And here, just below the TMJ or temporomandibular joint, just in front the tragus of the ear, we can do this rolling movement in order to feel the preauricular lymph gland. Postauricular lymph gland lies behind the auricle, and here we, over the mastoid process, and just in front of the mastoid process, we can do this rolling movement with the terminal phalanges of our right hand. And last, we are doing the suboccipital lymph gland, and just below the external occipital protuberance, which is the most prominent bony prominence on the back of the occiput, we can feel the suboccipital lymph glands on both sides. The same can be done on the opposite side, supporting the patient head and doing the same technique on the other side. After doing the circular group of a lymph gland, we shall not be missing the internal or the deep circular group lymph glands, which lies in the Valdeir ring, which is a collection of tonsils, lingual, palatine, and pharyngeal tonsils. Here we ask the patient to open his mouth using a tongue depressor and a torch to inspect this Valdeir ring. So asking the patient, راقي ممكن تفتح بقك؟ طلع لسانك قول طيب خلاص اقفل لسانك. This part of the circular group of lymph gland examination is essential in order not to miss a very important part of lymph gland enlargement or tonsillar lymphomas. During examination of the vertical group of the cervical chain, here the patient must be putting the muscle, which is the sternocleidomastoid, in action. And in order to put the sternomastoid in action, we have to ask the patient to nod, which is bringing his head downwards. نزل دماغك شوية وزق على ايديا. This movement is called nodding, and here is nodding against resistance in order to put both sternocleidomastoids in action. Again, we are using the palmar surfaces of our terminal phalanges in a rolling movement along both posterior border of a sternomastoid, which extends from the mastoid process down to the clavicle. Here we use it in a rolling movement to feel the posterior group of the vertical cervical chain. And alongside the anterior border of sternocleidomastoid, we are using this rolling movement in order to feel the anterior group of the vertical cervical chain, and over the sternocleidomastoid to feel the superficial cervical lymph glands. And after using this, we are feeling just in front, the anterior border of the sternocleidomastoid, where the jugulo-digastric lymph glands lie, we have tonsillar group of lymph glands, which are included among the anterior deep cervical lymph glands. They should be filled, and they are on both sides of the trachea. We have to make sure while examining the vertical group of cervical chain that we examine each side at a time, and the anterior group should not be examined simultaneously at the same time, and this may cause the patient vasovagal attack due to compression on the carotid sides. After we finish the cervical lymph gland examination, we have to give comment on the lymph gland, and those comments should include whether those lymph glands are enlarged or not, the anatomical subgroups involved in the cervical lymph gland involvement, the type of enlargement, whether they are matted or discrete, the bilaterality, mean the right side is involved or the left side is involved, the symmetry, whether those lymph glands are symmetrical, they are looking the same, they are mirror image to each other, the multiplicity, we are not giving a number of lymph gland, but we are saying if they are multiple or single or solitary lymph gland enlargement. We're giving comment in relation to the tenderness. And while we're examining the gland, we have to inspect the patient's facial expressions, whether he feels the tenderness or not. We have to give comment in terms of consistency of the lymph gland, whether they feel soft, firm, rubbery, or hard. In consistency, we have to give comment in relation to the surroundings, whether they are fixed to the underlying structures or freely mobile, or they are attached to the overlying structures, or they are not attached. And last, we have to give comments on the skin overlying the lymph glands, whether there are signs of inflammation like redness, hotness, dilated veins, opening, fistulae, or sinuses, which can occur with certain lymphadenitis like tuberculous lymphadenitis or with malignant tracts with the lymph gland. After giving comment, now we are finished with the cervical lymph gland examination. Thank you. Our third station, Osce station, will be regarding comment on the eye. And as a hematology spot, comment on the eye is referring to what we should convey regarding the eye color. I mean, the color we can see in the white of the eye, which is the sclera, or the palpebral conjunctiva of the lower eyelid. In addition, we have to mention any comments regarding the subconjunctival hemorrhage, because this may give an indication to the underlying bleeding disorder. So first of all, while examining the patient must be in a daylight, and we ask the patient to look straight forward. بصوا قدام يا رقي. We are pulling down the lower eyelid and inspecting the palpebral conjunctiva of the eyelid for any possible pallor. So if we see the lower palpebral eyelid pale, this is called pallor. The other part of the eye examination is examining for jaundice. So we ask the patient usually to look upwards. بص فوق. We are pulling down the lower eyelid and we are looking at the non-sun exposed part of the sclera. And at this part we can see yellowish discoloration, which is called jaundice. Here we have examined the eye in terms of colors, which is pallor or jaundice. In addition, inspection of the eye or examination of the eye can reveal an underlying subconjunctival hemorrhage, which can occur with a variety of bleeding disorders like platelet dysfunctions and coagulopathy. Thank you. Our fourth station will be lower extremity examination. This station will come in form of examine or comment on the lower extremity. First of all, we should ask the patient to expose his lower extremity up to the knee. So, راقي ممكن ترفع بنطلونك شوية لحد الركبة؟ شوية كده بس كفاية. Of course, we have to make sure that there are no tight garments or anything compressing on the lower extremity vessels, because this may alter the results of our examination. First of all, we should do a sustained pressure on the dorsum of both feet for at least 20 to 30 seconds. After we do the sustained pressure, we release to see any possible pitting. If there are pitting, or if there is pitting in both limbs, this is called pitting edema or positive pitting test. The same should be done in the right retromalleolar space. So, we are doing sustained pressure on both sides of the retromalleolar space. And then we release to see if there is any possible pitting. Retromalleolar space is important in terms of differentiating the edema, which is accumulation of subcutaneous tissue, from any causes of fullness of the lower limbs or increased limb girth like obesity. We'll do the same on the lower end or lower third of the shin of tibia. We do simultaneous pressure or and we release to see if there is any possible pitting. The last point we have to do this pitting test on is the anterior superior iliac spine and the sacrum if the patient is in a recombinant position. If the test is negative, we do not have to proceed so long. However, if the test is positive, we have to proceed on the subsequent points in order to detect the extent of the edema. Comment on the edema should include whether it is pitting or non-pitting and whether it's unilateral or bilateral, and there are many differentials to unilateral or bilateral pitting and non-pitting edema as well. The other station regarding examination of the lower extremity is to comment on the lower extremity in terms of bleeding signs and symptoms. And bleeding signs and symptoms usually come in form of purpura, petechiae, ecchymotic patches. And here we have to do planching test. And the planching test is using our thumbs to do a pressure on this part which has shown some kind of a depigmentation or hyperpigmentation of the skin, bluish discoloration, reddish discoloration of the skin, which is the suspected purpura or petechiae. And if it planches or it fades with pressure, this is called positive planching test. If it does not fade with pressure, this is called negative planching test. And usually, petechiae, purpura, and ecchymotic patches being intradermal and subcutaneous extravasation of blood, they are not planchable. They do not planch with pressure. Then we have to give comment regarding the extent of those purpurae on the lower extremity. And that's all regarding the lower extremity examination from the hematology perspective. Thank you.